Thank you very much, Dr. Abdullah Rosano. As usual, really this meeting is a good meeting because I like it a lot. Only 15 minutes talk, or cut off the chap, come to the point directly. And so every year I'm getting more and more encouraged to attend this meeting in a very delightful and a very enthusiastic manner. So we have been focusing so much on the coronary artery disease and the heart failure, but we have to really remember one of the silent killers in clinical practice is DVT and the consequence, which is pulmonary embolism. And as you can see from this slide, the overall trend or the fatality rate is coming down because we have become better in treating with pulmonary embolism, but at 10% still remains 10%, which is far more higher than the STEMI mortality, which is in the range of 3.5 to 4%. So we have a lot of emphasis on STEMI management, but people tend to ignore and they tend to think that the pulmonary embolism and the DVT is kind of a little bit benign disease. The current guidelines, the European guidelines say that if you have a patient with a high-risk pulmonary embolism, and what is high risk, we will see a little bit down the line, then the first test of choice is actually bedside transthoracic echocardiography. And coming back to cardio, why it is because easily available and can be done very rapidly. Cardiologists are good at interpreting. And if you find a synovial dysfunction, this is very good. But if you don't find any synovial dysfunction, this is a very important point for the purpose of the test. This means that it doesn't make a high-risk pulmonary embolism likely. You have to really search for other cause of hemodynamic instability. That means what? If you have a high-risk P, then RV dysfunction is a must. And there are a number of features which you can see in the high-risk pulmonary embolism. You can actually see that the right ventricle is dilated, the left ventricle is very truncated, and if you look at the short axis, the tomato slice view, you can actually see that the pressure changes in the right ventricle pushes the septum or the left ventricular side and the in diastole. Not only that, there is a significant tricuspid regurgitation, which is seen very clearly. And if you look more carefully, and in some cases, you can even image the clot in the pulmonary artery by doing transthoracic echocardiography. So these are the patients which you can see a lot of things in the echocardiography, it gives you a lot of information regarding such a patient. Now, why this is important? And the guidelines say very clearly that when you get a patient with PE and you think of PE, it's very important to risk stratify. Because on the one hand, on the right-hand side are the patient with very mild symptoms and when the expected mortality to 1%, which is very, very low mortality. But on the other hand, we have the patients with the high-risk patients and with the PE-related shock where the mortality can reach 30%. And how do risk stratify in clinical practice? By looking at 4 simple parameters. And the first parameter, if you have absence of these all 4 parameters, then you make the patient very low risk and he comes at the bottom of the chain and the risk is mortality is 1%. However, presence of all the 4 features, which is a clinical shock and hypertension, and obviously clinical shock and hypertension is very, very important, or RV dysfunction echocardiography or CTPA and biomarker elevation makes the patient at high risk and the mortality can go as high as in the first 24 hours up to 15%. However, if the patient have discordant pattern, that means hemodynamic is stable, but you have elevated biomarkers, RV dysfunction, we call this category intermediate risk, and the intermediate risk have obviously intermediate chance of complication regarding mortality and morbidity. So is the cardiologist usually gets called up when the patient is having high risk pulmonary embolism. So this is one of the typical examples of the patient we see in the practice that he's a 48-year-old man, he's a truck driver, and he came with shortness of breath 6-hour duration. He's hypotensive and he's hypoxic. And you can actually see whatever patterns I described to you before, that the right ventricle is grossly dilated. In fact, it's nearly 1.5 times that of the left ventricle. Not only that, you can see there's a trapping of a clot inside the trabecle of the right ventricle. So this right ventricle is not leaving the left ventricle, and some of the pieces, obviously, clot has gone to the pulmonary artery, and that is why the back pressure changes are there. Not only that, you can even see the longitudinal state of the right ventricle reduced significantly, and this is an important point which we see in the practice that we don't do it very common, but if you acquire the images, you can do a post-processing, and in this patient, you can see the right ventricular pressures are the range of 65 millimeters of mercury. This patient obviously had a very big pulmonary embolism. We thrombolized it immediately, and he had a very good recovery, as you can see down the line, and I will show you what the guidelines recommend in the practice. So these type of patients, of the high-risk patients, they comprise 5% of population, but they have a very high mortality. But unfortunately, or fortunately, in the clinical practice, the intermediate risk pulmonary embolism is not uncommon. It approximately 40 to 50% of population, intermediate risk population, putting as a challenge, how do we approach patients in this population? These patients have high mortality of nearly 20%, and so they cannot be taken lightly. So we can say that can we thrombolyze all these patients? And there was a dedicated trial which looked in these patients for giving thrombolysis for the patient with systemic intermediate risk pulmonembolism. And this trial turned out to be kind of disappointing. Although the hemodynamic collapse reduced nearly two-thirds in this population, but this came at the cost of very high risk of bleeding, nearly 10%, and the hemorrhagic stroke become an unacceptable 2.4%, making it as a very, very poor choice to use in the routine practice for the patient with intermediate risk pulmonary embolism. What about the high-risk patients? So we know the guidelines say for high-risk patient, thrombolysis is a class 1 indication, but for this population, if you see overall the population at high risk, only in real life, 25% of them, they receive lytics. Why they receive 25% receive lytics only? Because 30% of this population have some form of contraindication, and 30% time the doctors are afraid to give because the patient is elderly and there is risk of bleeding for him. And so there is a high risk of bleeding in this population with thrombolysis of nearly 9.9% in this population. So this means that there is a lot of limitations in using thrombolytic as a first approach for high risk pulmonary embolism or for the low risk pulmonary embolism. So the question comes to us, can we look at the catheter-based devices, which the invasive cardiologists are looking all the time? And the guidelines they recommend this catheter-based devices as a class 1 indication for surgical approach, but for the interventional approach, it is only class 2A recommendation. But this will change, I am sure, in the next guidelines. As you can see, there is a change in the pattern of the pulmonary embolism. So these are the guidelines which came in 2020, but last year, the European Society of the Working Group of the Interventional Society, they released a paper for the catheter management of pulmonary embolism. And they actually highlighted there are 12 or 13 types of devices available currently in the market, which are providing some form of intervention approach for the management of pulmonary embolism. And these devices can be categorized in the area in which you do a thrombus extraction, or you do catheter-assisted, ultrasound-assisted, or catheter-based thrombolysis. Among them, the thrombolytic approach is by the catheter base is coming into wake because the dose used for the thrombolysis is much more lower. Typically use 18 milligram or 20 milligram, unlike use 100 milligram alteplase for the patient, 100 milligram alteplase for the patient traditional dose we use for pulmonary embolism. And you can couple them with ultrasound. Ultrasound causes separation of the thrombi, and with the infusion of fibrin with the low dose over 18 hours, 24 hours, causing reduction in the pulmonary artery pressures. So what about the patients? I will skip some slides because we are kind of running out of time. So currently the guidelines recommend to do a therapeutic anticoagulation in the patient for 3 months minimum, but after 3 months, you can really stop anticoagulation discontinuation in those people who have a major transient reversible risk factor. So all of us in the room believe, and most of the people believe, that a pulmonary embolism is kind of having an isolated episode. The perception is that you have an episode of VT, then the journey of the patient is linear, and eventually he will live a normal life. But in real life, it is not like this one. In the near life, the patient with the pulmonary embolism is having a crisscross journey, and his complications are truncated or punctuated by repeated VT and the bleeding and the recurrence on the way. So as a physician, it is responsible to prevent recurrence at the minimal cost of the bleeding. How high is the recurrence? So typically, as you can see, the recurrence of pulmonary embolism occurs as high as 10% in the first 1 year and 6% by the end of second year. So a high recurrence rate of nearly 16%, which is similar to that of seen in acute coronary syndrome in the first 2 years of a episode of VT or pulmonary embolism. And subsequently, you have nearly 3 to 4% of recurrence every year. So by the end of 10 years, 50% of the patients will have some form of recurrence, making us important to have some form of vigilance regarding the onset or some form of pharmacological preventive therapy to prevent the recurrence. And that is why the recurrence occurs mainly in certain groups. For example, if you have somebody who's got a major provoked reason, for example, surgery, the recurrence rate is very, very low. But if somebody who's got an unprovoked PE, which is the type of patient we see in the clinical practice, the recurrence rate is very high. So hence some form of balance is required. You want to prevent the recurrence, but you want to not to increase the risk of bleeding. And all the drugs have been tried. So you can see the warfarin from the era of warfarin. The physicians have been vigilant about this point from the time of zimilagatan, which is the precursor of all the NOACs. So all the drugs have been tried to prevent the recurrence of this one. But current consensus is gravitating towards two molecules. And the two molecules is one molecule which has been studied, epexiban, which has been looked and in the lower dose, and the rivaroxaban in the lower dose, which have been found equal to the aspirin with regard to the bleeding. So what did the European Society say? The European Society says that only when you have a major transient provoked risk factors, which means post-surgery, post-fracture, post travel, in that case, you have a low risk of recurrence and you can actually give a short term of anticoagulation. But all other categories, which on the right hand side, some form of anticoagulation is needed. And the current recommendation is to use apixaban 2.5 milligram BID or a low dose of rivaroxaban in OD dose after 6 months to prevent the risk of recurrence. And more importantly, you should actually see for every 6 months, you have to reevaluate the patient, whether the patient requires continuation or the patient, the risk of bleeding exceeds the risk of benefit. So with this, I come to the end of the talk. I have only 30 seconds remaining. That certainly no doubt about it, the VT in the P is a silent killer and the high index of suspicion is needed. It's very, very important to risk stratify. You see a patient with P, you have to risk stratify. Look at the blood pressure, look at the PISA score, look at the biomarkers, and look at the echo pattern of the RV dysfunction. If you find all 4 of them, this makes the patient very high risk. Intermediate patient have intermediate risk. For the initial treatment, if your patient is very stable, patient can go home on NOAC therapy. Any other patients admit and start on peritoneal therapy. The European guidelines are put very clear which patient require extended treatment, and we should really follow this one. Except for major surgical provoked treatment, all other patients require some form of extension. So thank you very much for your attention.